So that, since you bring up a very important point, goals of care, and at this age of development, we're now curing prostate cancer. Metastatic prostate cancer remains incurable. But what is the goal of treatment? What do we try to achieve for someone with de novo or metastatic hormone-sensitive prostate cancer?
I think the goal is, of course, progression-free survival, right? And also overall survival, hopefully any treatment. Because historically, the data was like if somebody had prostate cancer, the median survival was like 38. No, I think it was less than that, even 38 months, maybe even less than that, 2 years about. But now the newer data that's coming out, I think people are living longer. And I think there was a recent study of the median survival was like 70 months. So I think the new treatments that we're introducing, I think people are living longer, hopefully living their healthier, longer lives, and then we're improving. I mean, these medications also have.
So we improve overall survival, and the benchmark and last benchmarks are based on the PEACE-1 trial. The median overall survival is 61 months. So beyond 5 years compared to what used to be 3 years, and just about 10 years ago. So that's a huge improvement. And what else? Improve overall survival. And what determines the survival of prostate cancer? And one of the goal is to delay the coming of CRPC, right? That's inevitable, right? For a patient with metastatic prostate cancer, now we're delaying it, but eventually it happens to majority of the patients. Majority of the patients will develop castration-resistant prostate cancer and eventually die from the disease. So thanks to the ARPI, I think, and we've seen a skew of the population now. We see more HSPC in our practice, and the CRPC, the wave of a CRPC has not come yet, but in several years to come, it may come to our door. Okay, so and when you see a HSPC, metastatic HSPC patient, is there any characteristic that you can foretell that this patient is going to be at higher risk of developing CRPC?
Yeah, the Gleason score is one, like the higher Gleason score.
What I have noticed with patients of mine that have kind of progressed more quickly were a lower PSA at the time of diagnosis versus the burden disease, so it doesn't match. Like they don't have those.
Fully differentiated non-PSA producing disease, right? Yeah, those patients tend to have a very poor prognosis,
Right.
And have a tendency to have germline mutation also. Okay. Yeah. So presentation, disproportion between the PSA and the volume of the disease, and there's a concept, and the prostate cancer with explosive voluminous disease, well, the PSA itself is not that high. So those patients do poorly.
And I've also noticed.
Go ahead.
After you do your whatever induction therapy you've chosen to do for their metastatic disease, if they don't have a PSA that's near undetectable at the end of your treatment course, those patients tend to
PSA nadir. So there are more and more presentation come up, even during the most recent ASCO annual meeting, and PSA nadir. And there's a different PSA test, ultra low PSA, and meaning PSA, the kit can detect PSA level less than 0.02, for instance. And does it matter? And do we need to have ultra low PSA?
Yeah, I mean, though though the, quote, aggressive variant prostate cancer features were really designed to assess metastatic castration-resistant disease, I do think about those in the castration-sensitive setting. So like you said, a low PSA despite high burden of disease, patients with osteolytic metastases, patients with elevated CEA, elevated LDH, patients with genomic features like, P10, RB1, or TP53 mutations. Those are all features that suggest a much worse prognosis. And so while those were studied in the setting of deciding who should, cabazitaxel and carboplatin in the castration-resistant setting, those are kind of guidance in terms of how aggressive we want to be, and also prognostication for the patient.
So now we're talking about, we are discussing about the adverse molecular features to foresee the prognosis of patient. Alex mentioned about 3 tumor suppressor genes, P53, RB, and P10 mutations. And this portends poor prognosis. And is there any molecular alteration that signify better response to treatment that may help you to change your treatment decision? SPOP mutation.
They have a better response to the ARPI, right?
Right. So if you have a patient with SPOP mutation, would you more inclined to treat the patient with ADT plus ARPI without docetaxel? Oh, we don't know the answer yet, right? We need a prospective trial. This is a very provocative finding, and there's ongoing clinical trial to evaluate a patient with the SPOP mutation in terms of treatment algorithm and strategy.
Dr. Haq, I think we can also look at platinum-based therapy,
right,
and PARP inhibitors too.
I think it's an interesting question of when do we do next generation sequencing, and as a very general principle, we should certainly do it at the time of castration resistance, but is there value in doing it earlier? And I would argue that there is, for several reasons. One is that sometimes we get tissue degradation over time, that by the time we get to castration resistance, I anecdotally have found that we have less yield in terms of NGS, as in it comes back saying the tissue is no longer useful. But also because we may identify things like microsatellite instability, which we see in 2 to 3% of cases and would dramatically change prognosis and potential usage of immunotherapy. Identifying, as you said, BRCA mutations probably wouldn't change first-line status, but you know what you wanted to do second-line. Similarly, where you'd have an SPOP mutation that might, perhaps lean you one way or the other in terms of how aggressive you want it to be. So I think it can be very useful, even if it doesn't change immediate management, to get that testing done early, so that we kind of have, all of the information at hand.
Now, are you only using tissue NGS testing, or do you use any type of liquid biopsy?
I do also send liquid biopsy. We have data that shows that across most of the platforms, about 10% of mutations that are found in liquid are not seen in the tissue. How clinically relevant those are those really the driver mutations, I think is an interesting question. These cancers have, spatial heterogeneity, meaning that, you may have certain, maybe certain tumors have, acquired some mutation that others haven't. But I do always send liquid. I find it helpful to have. It's also a little bit of a sense of disease burden in a patient with perhaps less metastatic disease. It also allows for a normal comparison. So I always send liquid at the time of diagnosis.
Yeah. There's a caveat with the liquid biopsy. There's a scenario called CHIPS, and which is happens with aging, and you may find CHIPS that may have nothing to do with the pathogenesis of the disease itself. If you find someone with ATM mutation, based on liquid biopsy, it's a real or chip. It sometimes can be hard to tell. So tissue biopsy sometimes could minimize the confusion.
Of course.
To re-biopsy at any point, like if it's been 10 years since the initial diagnosis?
So, yeah, the standard of care in truth is actually to biopsy at the time of castration resistance. The statistics will show that about 10 to 17% of castration-resistant patients will develop neuroendocrine transformation. ideally we would always biopsy these patients at the time of castration resistance and perhaps at every progression so as to detect neuroendocrine transformation. Now in reality, we don't do this. And the reason is because we get a bunch of bone lesions, which are going to have very poor yield in terms of biopsy. But anybody who develops visceral progression, I will always biopsy, whether it's in the lung or the liver. And if the bone disease appears particularly aggressive, growing fast, PSA skyrocketing, alternatively, lots of radiographic progression without PSA going up significantly, then I have a low threshold to get a biopsy.
Yeah, that's the ideal scenario, but in practice, most of the time it's really hard to do. For bone lesions, it's hard to do NGS study.
And it's hard to trust a lot of what you.
Right. And
Having that you left something.
well, for tissue, say if you have a patient with liver lesion and you cannot get too much of a core biopsy, the risk from the biopsy itself is too high to obtain a core. And certainly doable, but for academic interest, in a clinical trial setting, yes. And if it can obtain a fresh biopsy, that'd be ideal situation.
I don't do it so much for NGS as to look at the pathology. I'm really looking for a neuroendocrine transformation. In terms of NGS, I mean, you may find ARV7 variants. You may find resistance mutations, which don't really guide your management very much. But perhaps the day will come when we have treatment that's really guided towards, for example, there are now patients with ATR variants, which are suggestive of androgen receptor resistance. There are new trials looking at that, but fundamentally, I think we just need to have a low threshold to think about transformation, because if they have transformed, then nothing other than chemo is going to work. And if they're not a chemo candidate to begin with, then we need to have some real goals of care conversations.